Greetings, everybody. Thank you for those of you who are on camera and for all of you for joining.
LJ, can you hear me?
It's nice to see you. We'll give people just a couple of minutes. Uh-oh.
LJ, can you hear me?
Now I can. You
There's
cut out for a second there.
There's someone in the waiting room named Hale Bauer. Does anyone know who that might be?
I mean, my partner's name is Miriam Bauer.
What's the first name?
Hale, H-A-L.
That's not a relation
That's
to
her
Miriam.
It's not her children's name or her husband's name.
Hi, guys.
Hey, Pat.
Yeah.
Welcome.
I love that opening. Supposed to let you in soon.
I'm
Happy New
gonna
Year,
try
everybody.
and I'm going to try and message the waiting room. I'm, you know, with a lot of the shenanigans going on with Zoom bombing lately, I just want to be extra careful here.
Sure.
Okay.
That makes sense, Renee.
I like it.
So for those who are just joining, we're just giving about 2 more minutes, maybe even only 1 more minute until we have people slowing down, joining the room. Thank you for joining us tonight. Renee, do you think we're good to start?
Sure.
All right, awesome. Okay, so we have a pretty full agenda for tonight, and we have a couple of guests joining us at the very beginning. In terms of introductions for tonight, just to keep things moving and give you all as much time with your families and have your evening back, I'm going to do introductions in the chat. So please go ahead and put your name and practice you're from, or where you are, what your responsibility is within AHP. For our AHP team members who are here, go ahead and introduce yourselves. And then I am going to turn over the introductions to Dr. Nazra, who can introduce the guests who are joining us. You know, focusing on behavioral health is what you all are doing, is what we all want to be doing. And so we've got some nice information on enhanced resources in that space for you this evening. Thanks, George.
Thank you, LJ, and good evening, everybody. I want to welcome Kelly Vandermark and Amy Lyons tonight, who are joining us. Thank you for being here. We're going to start with Kelly first, who's going to introduce a new initiative out of the Department of Psychiatry called the Substance Use Disorder Primary Care. It's a resource for all of you as primary care providers specialize in substance use disorders, but also to refer your patients who need evaluation and treatment for substance use. And Kelly will introduce that program, as well as a new adolescent program in our department for substance use disorder. And then we're going to move to Amy Lyons, who's the coordinator for Project Teach. Many of you may already know Amy. And she's going to tell us a little bit more about the expansion of Project Teach beyond the traditional CAP-PC, now including maternal mental health program as well. So thank you, and let's start with Kelly, please.
Okay, thank you, everyone. Thanks for having me tonight. I'm happy to be here, and thank you, Dr. Nazra, for inviting me. Is it okay if I share my screen? I'm sorry I didn't get to share these prior to get it to you. So let me just get this. Can everybody see this okay? Okay. So I just want to share our newest initiative, which from Strong Recovery, which is substance use disorder treatment in primary care, SUD-PC. Some of you may not be familiar with Strong Recovery. Strong Recovery is our outpatient addiction psychiatry program. We're located over on West Henrietta Road, and we offer a slew of services for adolescents, young adults, family therapy, individual and group therapy as well. So we have a new initiative that we have started within the last 6 months for primary care. And it's called SUD-PC, and we're a mobile unit of addiction professionals. So we have about 6 CASACs, which is credentialized alcohol and substance use counselors, that are accessible to the primary care offices. So we want to just make all of you aware of this, because during COVID, many of us are dealing with long waits to get into mental health services and substance use treatment. So we want to make sure that we reduce any delays and have quick accessibility to treatment and to services. And one of the great things about this program is that we will come to you. A lot of times patients are really contemplative. They're not really sure whether treatment will fit into their lifestyle or their schedule. And we will come right to the primary care office. We can complete an assessment there and make a recommendation in collaboration with the provider so that we can best treat that patient. So some of the departments that we have been working with so far is the emergency department. We really just came together with this group in the last 6 months. I was working with primary care in the primary care network, your primary care network. It's been going on almost 2 years, which was kind of like an introduction to getting behavioral health services such as substance use in the offices. And we're just expanding on that. So we want access to emergency department. We help with overdoses that may happen, and we want to quickly be able to offer resources to the patients. There's a new program in the hospital, which is called G92 Summits. It's a 10-bed unit for patients. It's a medical psychiatry unit for patients who require a longer hospital stay related to their substance use disorder, such as endocarditis or pancreatitis, or maybe they have liver damage, or they're just there for maybe 6 weeks or less. And we offer group and individual therapy, as well as linking them to treatment beyond their inpatient stay. We also are working with OBGYN, high-risk pregnant patients. We want to get them into treatment as quickly as possible. And if they're in need of medicated assisted treatment, such as methadone or buprenorphine or Vivitrol, whatever it may be, we want to be able to have a resources available for the women. Working with Highland Family Medicine and Strong Internal Medicine, going right to their offices and completing evaluations there. We're available to all of your primary care offices, and we want to be able to work with accountable health partners as well, starting to expand beyond what we offer right now as well. We just want to make sure everyone's aware of this new initiative and that we're accessible for your patients. We have a substance use counselor in CPAP, a full-time counselor that's there at all times, because that's really a high utilizer of patients that are in need of substance use treatment and mental health. And we also recently have been working with the liver transplant unit. So many of these patients need to be in substance use treatment, but non-traditional. They are maybe too medically compromised to get into a regular treatment, substance use treatment. So we'll meet with them individually or go right to the doctor's office to try and provide individual therapy, just to monitor them, to make sure that they have the supports in place so that they can receive that liver transplant. This is just an overview. So the way that we are getting referrals is through the emergency room, inpatient, and outpatient ambulatory with primary care. So what we'll do is we will triage and provide rapid treatment recommendations, and whatever that level of care may be, it may be detox or methadone clinic, or not necessarily even strong recovery. We can refer to Rochester Regional, Westfall Associates, Conifer, wherever it may be, whatever the needs of the patient, that's what we're going to go with, the quickest way that we can get them in somewhere. And then we'll follow them until they can get into that program. A lot of times right now, there's a lot of wait to get into an inpatient rehab, and the hospital cannot hold them bed to bed to go from the hospital to an inpatient. So we're kind of filling in that gap so we can meet with them until we can transfer their care to inpatient. And then when they're done with inpatient, they can come back out and meet with us. So it's really the continuity, and we want to create stabilization for them as much as possible. Once they're stable, we'll refer them back to primary care or behavioral health. If there are Suboxone in providers within primary care and the patient's much more stable, the primary care provider is more likely to take them back instead of early in recovery. So this is just a little bit more about our initial level of care evaluation. We really, when they're inpatient in the hospital, we try and meet with them. Now, you guys work with the adolescents and young adults. We had a case recently where I think it was a 16 or 17-year-old had taken a bunch of acid and jumped out of a window and broke both of his arms. So his parents were beside himself, obviously, and we were able to meet with them in the hospital, link this patient to care, and we get them at their most vulnerable time. So it's really a good time to try and engage them and offer the family services as well. So we utilize peers as well. They're part of our team, which seems to be very beneficial to the patients. They like knowing that there's others out there that have successfully been they're in recovery, and they're providing support such as like eating disorders. They can provide additional support and gender identity issues. So there's just a lot of additional resources that are available with the peers. This is what our team consists of. Not only is it the credentialized substance abuse professionals, but it's addiction psychiatry, mental health therapists, physicians, nurses, social workers, the peer advocates, the family therapist, and voc ed. As far as the adolescents go, we do offer telehealth as well, but the adolescents and teens tend to do much better in person. When we were going, through COVID and having a lot of telehealth services, the teens did not do as well with that. So we do offer the in-person as well. We're kind of hybrid, doing both. The nice thing with the adolescents at Strong Recovery is they have art therapy, they have music therapy, and they have like group rooms full of beanbag chairs, and it just makes it really more comfortable for them. And this is our team, -1. So this is, and we have bilingual as well as on our team. So that makes things a little bit easier when we're working with Spanish patients, Spanish speaking patients. The one person that's missing on this picture is Jackie, who's in our CPAP, one of the counselors in CPAP. We do have e-consults as well. At the very end, I think Renee has our flyer, and I can make sure that all of you get that. So if you ever have questions provider to provider, we have an e-consult that you certainly can use to discuss about medications or some patients that are very complex. Also, how to deal with some controlled substance, maybe agreement that may have been broken, or patients that may need assistance with tapering. We do that as well. Just a little bit more about our additional services. We can link family members to treatment options. A lot of times the patient may not be interested in treatment, but the family member is, and you do not need to have the patient involved in treatment to have a family member involved, if that makes sense. We can offer family therapy and just really offer support, because a lot of the parents or spouses are kind of at a loss. They don't know what to do, and we can link them to support services. The adolescents at Strong Recovery we treat as 14 and up, and we ask that the families are involved in it as well. So it's kind of dual purpose, that the patient of the teenager gets support, but as well as the family. We can help with any Narcan. So out in primary care, if anyone who's prescribed over 50 milligrams of an opiate medication and they can't afford a Narcan prescription, please reach out to me and I'll make sure that they receive one. We want to make sure that everyone has accessibility to Narcan. And we still help, like I said, with opiate tapers or with benzo tapers. If you have patients out there that have been prescribed for quite some time and you feel it might be best that they taper down to safer doses or taper down altogether. A little bit about our adolescent young adult program. The age of the adolescent program is 14 to 18. We work a lot with the school districts in engaging the patient. And then 18 to 24 is our young adult program, the college kids. And like I said, we try to involve the family members as much as possible. We see a very large number of young adults that are experimenting with use, and they get into whether it's legal trouble or they just become physically dependent upon opiates very much younger than 10 years ago. That's for sure. It's definitely something that we're concerned about, but the resources are there. We definitely have the resources, and as well as, you know, other areas in the community. Rochester Regional has a great adolescent program, and Westfall Associates. We utilize all of the community treatment centers. This is how to refer to us, which there's a flyer that we'll make sure that all of you have. And this is just a little bit about Narcan trainings. This is on the intranet at with U of R. So you always can sign up for any one of these trainings or have your patients or family members sign up. They get a free Narcan kit with each training. It's probably about a half an hour long. And that's pretty much it. I didn't want to, I kind of zipped through it, but I wanted to make sure that you guys got a general idea of what this consists of. Does anyone have any questions? No?
Thank you very
so much.
Okay,
Yes.
thank you. Yeah, feel free to reach out if you ever have any questions or even just don't know where to turn with the patient. We're here to assist and help. So thank you so much for your time.
Just one point, Kelly, to clarify. If someone calls this number, if they are not part of the EPIC electronic record, they call this number 507-8300. Oftentimes I get you when I call this number. Is that what's expected?
Yeah, so usually I'm the triage person. I'm kind of doing the initial talking to whomever it is about the referral and then sending out the troops as to wherever they need to go. So keep in mind, we try to see patients as quickly as possible, and there are wait lists all over the place out there, and this is the quickest, fastest way to get someone into treatment.
So there's a question from Dr. Walsh. If a practice or a provider calls this number and are requesting an evaluation, what's the time frame for someone to come into the practice and see the patient?
Well, it really depends on the patient. Like we probably wouldn't be able to see them that day unless it was an urgent request, but we would definitely coordinate as quickly as we could to see them. If it was something that was urgent that day, just give us a call ahead of time, and we'll try to make it work, because we are covering a lot of area, and there's 6 of us, like I said, so we do have the bandwidth to see a lot of people. So just call and we'll try and make it work.
Thank you very much, Kelly.
Kelly and George, is this a model that's used elsewhere, or is this unique to this area?
As far as
I'm not aware. Yeah, go ahead.
I was to say, as far as I know, this is one of the newest mobile units. I'm not familiar with it being used anywhere else. I know Rochester Regional is kind of eyeing to see how we do with this. And there, a lot of other agencies, they may have a CASEC in the emergency room, but not throughout the whole hospital. Highland Hospital has New Focus, which will go to do consults with patients. But I'm not familiar with anyone going out into the primary care offices.
Thank you. Colleen asked if it's only for Monroe County.
No, anywhere you're affiliated with U of R, we will go.
Okay.
Thanks
Thank
so
you.
much, Kelly.
Okay, thank you.
I'm mindful of the time, and I want to introduce again Amy Lyons to talk about Project Teach.
Unmute. Okay, there we go. I recognize so many people, names on this call, many that I think I just spoke to a couple days ago. So I just want to let everybody know a little bit about how Project Teach has changed. In 2021, we are starting fresh with a new grant cycle, and we're going to be including maternal mental health. I'm going to share my screen right now and go through my slides real quickly. So for those of you who know, Project Teach has been around since 2010. We have registered, as of December, over 3,700 primary care providers across the state. We have done 15,000 plus phone consultations, 3,400 referrals, 1,100 face-to-face evaluations, and we have offered clinicians 29,598 free CME credits. So it's been a really great program. We were waiting, patiently to hear whether we were going to be funded by the Office of Mental Health for another 5 years. And we did hear that August or September, I think, at the end of last year. And some changes for, Project Teach. We will now be covering the entire state. I don't know if people are familiar, but the state was broken into 3 regions, and Project Teach regions 1 and 3, which was Rochester, Buffalo, Syracuse, Columbia, and Long Island, were all part of our group. And then there was a 4 Winds group that did Albany and Westchester in those counties. So now the state has combined everybody together in one program, Monday through Friday, for all pediatric and perinatal clinicians. Again, social workers, school-based clinicians, anybody that has any need for psychiatric consultation or referrals. We are going to be offering new trainings in 2022. So the clinician would call our toll-free number and ask the question. The liaison coordinator, which is myself, or the other liaison coordinators across the state, would answer the phone. And then we can provide linkage and referral information and schedule you to speak with a psychiatrist. We do have our team of Jim Wallace and Mike Scharf in Rochester, and now we have maternal mental health providers that are going to be part of our team on Fridays. But Monday through Friday, you'll be able to speak with a reproductive psychiatrist or anyone who is trained in maternal mental health, perinatal mental health, and as well as our child and adolescent services. We are going to have 2 yearly intensive trainings, which are a little over a day and a half with a lot of really in-depth information. The core trainings that we've done since 2010, I know many of you have taken the trainings. We always covered ADHD, anxiety, depression, and aggression, and we are going to be expanding what we're calling Core Training 2.0. And so I'm really looking for themes or issues that providers have that they would like more information about. I'm thrilled to hear about Kelly's program because we get a lot of calls for substance abuse issues, and we really do not have experts in that area. Then there's also online training on our website where you can tap into previous trainings. We're going to be having webinars and follow-ups for after the intensive training as well. So Our hubs are Albany Medical Center, Columbia, Montefiore, SUNY Upstate in Syracuse, University of Buffalo, University of Rochester, and Zucker Hill Northwell Health in Long Island. So our U of R team, I'm the liaison coordinator. Jim Wallace is our child and adolescent psychiatrist, and our reproductive psychiatry team, Jeffrey Eiler, Dr. Nazra, and Ellen Polishuk. And Mike Scharf is also our site director, but also does cover psychiatric consultations as well. This is a flyer that is in the work. So I see that right on this mom's tummy, there's the word big. So that is because it's from Big Stock Photography. It's not that her stomach is big or anything, but anyways, that's the photo that they're considering. So we have been working tirelessly with marketing people and, you know, the new teams that are being formed. And we're really trying to pull everything together and kind of have a grand introduction about the new services that we're offering. So I just wanted to open it up to any questions or any other ideas that people have for ongoing coursework. I also wanted to just go on our website real quickly. So our website also is being updated, but if you do want a consultation and you want the best team, you know, call on Friday, but you can call any day, Monday through Friday. And also we are now having online consultation requests. So if you don't have time to call, you can put some information in and have one of the psychiatrists or maternal mental health professionals call you back with some consultation information. So that's kind of another new part of our program. So that's about it for Project Teach, which was formerly CAP-PC, then Project Teach Regions 1 and 3. And now 11 years later, the whole state is part of our program altogether. And it's pretty exciting to think about how desperate people are for mental health treatment and to know that you can have a real-time psychiatric consultation the day you call at the time you need it. So we're here.
Congratulations to your team, Amy, and thank you for your work, and Kelly also for the work that you're doing. I'd love to, I know that a lot of our clinicians who are on this call utilize CAP-PC, Project Teach. Oops, that was a big slip.
Oh, I do have to say.
Anybody who trained in it when I did still thinks it is CAP-PC. So I wonder if folks have any questions or comments or anything they would they'd like to bring forward. So Carolyn Cleary is put in the chat. I'll read the chat out a little bit
Great,
too, Amy.
thanks.
Will you be advertising the maternal health consultation to OBs and adult PCPs as well?
Yes, definitely. So we are preparing all kinds of marketing strategies with our new marketing team, which is called Jibe. And they're going to be doing email blasts and flyers, press conferences. They're really going to be very active. I guess it was kind of tricky because we received the grant, but we really couldn't start till January 1. And I feel like so much is happening now that I wish we would have been able to do some of this groundwork in December, but we will be reaching out to family, medicine providers, OBGYNs, to let them know about the new services from Project Teach. Yes. Parent training. Yes. We are also adding some specialty consultants to our team. And I believe Kenya Malcolm is going to be part of our specialty team that is going to deal with, specifically with parent training and early childhood issues. So I would love to touch base with anybody. I'm on global, email. So Amy_Lyons, if anybody has any questions or other comments, I'd love to pass them on to the team so that we keep doing what is really helpful for providers. So that's our goal.
Thank you so much for that. I'm sure Dr. Waniel will connect with you definitely around that. Any other comments or questions from folks who are here tonight? You are all an uncharacteristically quiet group this evening. It's been a long day, right? It's been a long year and it's only 1 month. Is it a full month into the new year? Good Lord. All right. Well, again, Amy, Kelly, thank you so much for joining us this evening. And if other questions come up, we'll make sure that all of the contact information is shared and the other resources that you shared ahead of time with the teams.
Great.
Fantastic.
Thanks so much for inviting us.
Take good care. Thank you. So moving on to the next part of our agenda, which is still related a bit to behavioral health in terms of trauma-informed care. I was going to turn it over to Kristen Luce. We wanted to just do a quick follow-up with you all about the comfort boxes and the trauma-informed, approaches to vaccination, since there's a heck of a lot of vaccinating going on and will be going on coming up soon. We'll talk about that more later on in the meeting. So Kristen, did you want to lead on the conversation a little bit, just getting feedback from folks?
Sure. I was just kind of interested to see, if the practices who have already received their comfort boxes and the educational materials and training materials around it have found it helpful, if they've had time to review everything, try it out, and where things are kind of at in the practices with it.
I have a great timely story from today. Can I share it?
Share away. Yes.
Okay. So Kristen works out of our office, so we get to speak with her in person. And we have a nice comfort box, and we've been able to speak in person about trauma-informed care around vaccination and around other areas. So we had an 11-year-old new patient today that came in. So never met him or the mother before. And he was crying once he knew at the visit that he would get the meningococcal vaccine. He'd been asking in the car the whole ride there if he'd be getting a shot. She didn't know because she wasn't aware if he would be, so she just didn't know. So the nurse alerted me right away that he was anxious and upset because he knew he'd be getting a vaccine. So we decided to just go back in the room before we did anything else, ask him if he wanted to get the vaccine done with, and before his visit started. He decided that maybe that was the best thing for him. So we ordered the vaccine ahead of doing anything else in the visit. Obviously reviewed his allergies, things like that, but didn't plot his growth, I didn't print out his, forms or anything ahead of time. Just both of us went back in there. We got the box out. I showed him what he could look at. I showed him the Buzzy Bee. He chose what he wanted out of it. We got him his prizes. The nurse drew up the vaccine. He chose the bee. He chose a few other things to look at. He was crying, but we said, we understand he's upset and scared, and this is a scary thing. And the nurse gave the vaccine, and he afterwards laughed and, cried a few more tears, but then laughed and said, oh, that was easy. And we left the room, let him collect himself. And the rest of the time he was smiling, and the whole visit went great. And he, again, was giggling the whole rest of the visit, saying like he couldn't believe how easy that was for him. So it went from a very scary initial visit to a very happy, fun, light visit. So it was very good.
It was a great story to share, Kathleen. Thank you so much. Any feedback from others on the call? So the one thing I'm curious about, and you don't have to divulge, but you can share private feedback too. But one of the things we worried about with any kind of initiative, when something, sort of new tool or new resources brought into the office, it's really easy for it to be put on a desk or on a shelf, or, and that is just life, right? There's a million things you all are doing and trying to implement something, something new, may be well embraced by the team, or it may not be. And so just curious if people have had any barriers to using it, or found certain ways that it's been more effective. I know that we've tried to connect with the nurses in your practice to kind of have a champion in that space, but we'd like to support your teams more if there is anything that we can do so that it is being utilized more. Any successes or barriers that people have had or questions they have?
Kristen and LJ, how many comfort boxes have been distributed?
I think most of ours have been. I know there might be a couple still needing to get out because of some care managers who have been sick or out for a certain reason. But I think most of them have been delivered.
So nearly every practice would have received one? Okay.
Yep, that's my understanding.
And Dr. Wirt will get yours very soon. Okay, so there's some of the practices and they do not have them yet. So this is helpful. So let us circle back around. So at Asante, we are still preparing boxes for some of the other locations. So we will make sure that that is taken care of for Canandaigua Medical. We'll connect with you specifically around that. But I'm seeing Elmwood not having one yet and 12 Corners not yet. Okay. And West Side Peds as well. Okay. So let's be sure that those things are, so we think that some of those are out there already, but let's find out where they are in this process. And then we've asked for our care managers will do a little bit of orientation to that box for you and for your staff to make sure that it gets implemented well. Thank you. All right. So I want to switch gears a little bit. The rest of our agenda is really focused on things that we are doing right now, looking forward to what we need to be doing for we're in 2022, but just outlining the measures we're responsible for and what the quality, clinical quality improvement kind of work we're going to be doing. And then I wanted to give some time just for an open dialogue around COVID stuff. And then any other things that you all would like to bring to the meeting. So I have one slide to share around 2022 quality measures and clinical initiatives. And that's it for slides. And then I really do want y'all to talk because I'm going to not be sharing anything else, just looking at your faces. So this is just a really brief summary because for our pediatric quality measures, there are no surprises for 2022. Our measures are all of the bread and butter pediatric things that you all are doing. Well child 0 to 15 months, that's 6 or more visits in that time window. Childhood immunizations combo 3, which is no different than before. As this past year, adolescent immunizations combo 2. The one thing you'll see that's missing there, there's a whole regrouping within the HEDIS metric now, looking at the well child visits for the older kids, for the toddlers on up. And so those are not going to appear on our quality measures this year. There needs to be some baseline work done to see like what the national averages really are, what the standards are. It doesn't change our focus on preventive visits from 0 right up till, for our 21 plus kids, but you're not going to be measured in those spaces, though we will want to be doing some tracking and see what it looks like we're doing in this broader grouping that happens. And then the other thing that you will see is not here is lead screening. We talked about this at the last pediatric PCP advisory group meeting, that with the difficulties and the recall and the lack of resumption of operations for the lead care 2 machines, we specifically requested that measure not be included this year because it's so difficult for you all to meet it without the point of care. That being said, I did want to just update you all that Elizabeth Sharp and I had an opportunity to have a Zoom meeting with the leadership team from Magellan Meridian Bioscience, who manufactures the lead care 2 machines and all of their kits. And they gave us as much assurance as you could get without them giving us a date that they are very close. They have identified the problem. They have things going through the FDA to make sure they're getting approval that there is a fix. And they are anticipating resuming production later this spring, is what we were told. So I still don't have any date, but it was a positive interaction. I think they understand the importance of this and the impact this has. on preventive screening for kids. So just want you to know about that. Talking about adolescent immunizations combo 2, we just wanted to highlight, as a community, we are doing, if you look at national measures, we're doing okay with HPV vaccination, but okay with HPV vaccination is like just barely hitting 50% of eligible kids. So we're sort of going to do another little re-up push again with all of our practices, taking a look at if there are any resources, supports, things that would benefit your teams, your nursing teams, or your general workflows. And one of the resources that is available, I know that the Monroe County Medical Society shared this out just last week. And we've met with a team from the American Cancer Society who are conducting an echo, a 4-session echo. You see the dates are on there on the screen. It's a 1-hour session. And what they do in that is really try to help look at what are some of the best practices that you can do in terms of identifying when patients are due, in terms of the conversations that are had, resources that are given. So we wanted to just highlight 2 practices if anybody wants to participate in that. They will make, their registration had closed, but they will make a special exception for our AHP practices. If any of you would like to participate, please message me in the chat or send me an email so that I can up your practice's name to this. And Elizabeth and I are going to be attending this echo from AHP's perspective, just so that we can take and then translate any of these resources and suggestions that they have as we work with your practices over this next year. And then in terms of clinical initiatives, no surprise, we are really still trying to encourage and support our practices in providing, very good reproductive health counseling for teens and young adults. And then also, some specific education around LARC to be able to share with patients as it being the most effective form of contraception. And at the same time, we're also looking to see if there are any providers who didn't previously train and want to be able to place Nexplanon. There are trainings that can be scheduled for that. So you'll be getting a survey coming out very soon, just sort of confirming kind of what we know or what we think we know about what practices have participated already with the Huckelman Center Reproductive Health Counseling sessions. And then what providers are already LARC trained. And we realize we may not know everyone. So we're just going to do a brief survey to see where people are. And then if you have interest in pursuing that further. When we roll out our provider engagement report, which will be coming in the next month or two, couple months, we are going to highlight the work in LARC and its impact on reduction of unintended pregnancy. So there will be an opportunity for those of you who have participated in the Huckelman Center talks, those of you who have trained to be a LARC provider to get some extra credit, in terms of your engagement in an initiative. And we hope that our goal is not for all of you to train to be Nexplanon placers or providers. It's really to make sure that patients are really getting a well-rounded conversation from their care providers and being offered appropriate resources, whether it's placement in your own practice or by you, or referral to someone outside of your practice. So that's really the intent there. We're continuing our work in depression screening, thanks to Elizabeth and George and Willie and our team. So watch for more progress along that. And then also for those of you who started participation in our comprehensive developmental screening pilot, we are going to pick that back up again. I think we felt very much that there was only just so much anybody could do over the last 3 months, 6 months, 9 months. Every time we thought we were getting close to a point, we're like, let's re-engage. Then, the next wave would happen or the next shoe would drop. So we've really been trying to be quiet with you all in many ways about asking you to do more or different things, but it will be really nice this year to get back to thinking about more preventive strategies or exciting things that we can do in terms of partnering that make a difference for kids. So we're looking forward to that, and we'll look forward to more conversations with you. And the last thing I just wanted to say is just for those practices that did engage with some nursing training around the universal newborn screening pilot. We put a pause on that as well because clearly it was impossible with the nursing shortages and with the demand on nursing staff for all of the other patient care services that needed to happen. We are exploring some kind of cool opportunities, hoping to restart that pilot again in a couple of months, but doing it in a different way where we provide additional support to the practices engaged, but tie it into, connect with those nurses who did train and are great champions within your practice, but definitely lifting a little more of the work centrally. So please stay tuned on that. I don't have anything specific to offer. And I just wanted to thank Nikki Spring, who was on the call today. Nikki did just a great job and continues to do a wonderful job in her championing maternal infant health and helping us think about bridging this connection and making this program be more effective for our practices. So Nikki will continue to lead in that space. And she made great connections with many of the nurses in your pediatric practices. So that's really the bulk of the prepared conversation for tonight. I can do more if you want me to go into more detail, for example, about return to play revisions or things like that. But I actually wanted to just open the COVID roundtable conversation to all of you to see where are your pain points, how are you doing, what are the questions you have. And my one specific question for all of you is about being prepared for vaccinating the under 5-year-olds, the 6-month to 5-year-olds. So I'm going to lead off with that and to get people talking a little bit. We know at the time when we were getting ready to vaccinate the 5 to 11-year-olds, some of you were able to stand up vaccine clinics in your practice and vaccinate kids as you went in your day. And that was just amazing work. And other people did not have the staffing to be able to do that, certainly had the will, but didn't have the staffing to be able to mount some of the clinics where I think, those first few weeks where people absolutely wanted to get in as fast as they could. We know that parents, the younger the child gets, the more that parents are going to want to have their child vaccinated in your practices. So I'm just curious, and we're curious, do you feel like you're ready to be able to take all that on within the next few weeks? Do you feel like some additional resources, referral to some of the county sites, to the GCH centralized clinic site would be helpful to you? What can we do to prepare best so that we're working together still?
I'll jump in, LJ.
Thanks, Mary Beth.
We can't wait to get that vaccine in our office. I mean, the first 2 weeks of patients coming in are just ecstatic to have access to the vaccine. It's super fun. It's super easy. Their kids are generally excited about it because they sense how thrilled the parents are for this opportunity. So that part's pretty easy. We, bring in dinner and pay our nurses double time and buy balloons and make it fun. And everyone's very happy for that. After that comes the slog of trying to talk the, 70% of decliners into it. And that's been really tough with the 5 to 12-year-olds. I mean, I'm pretty successful at talking people into getting every other shot, but this one's hard. There's not even a lot of dialogue that happens. They're pretty concrete in their decision before I even bring it up. I say, now what about the COVID vaccine? And they say, yeah, no, thanks. And I can't even, tell me what your concerns are. We watch all these motivational interviewing things. To do motivational interviewing, you have to have a two-way dialogue. And I find that just doesn't usually happen. Just no thanks. No, we don't want it. So that's tough. But we're ready to get those early ones in. That's fun.
Okay, good. Yeah, Mary Beth, you just summed it up so well. I think there are, it's little wins, right? It's being able to do it when people come in, they're ready. But, I don't know if you all are, I'm sure you've been reading the news, like the national rates vary greatly, but recently the AAP put out that about 29% of 5 to 11-year-olds have received their first dose when they average it out across the country. So we've looked at our averages, you know, Monroe County is at about almost 39% right now. So we are above the national average. If you look out the entire Finger Lakes region, that is, those rates are closer to around 33%, and there's a huge range, depending on sort of where you look. So I think what I want to say is, I think everyone has been doing amazing work in this space, but it is not for lack of effort or for lack of availability of vaccine. It really is this, you know, disinterested or frightened because of disinformation. So thank you for sharing. Do others have feedback about that? Daryl.
I'm just curious about Mary Beth, when folks say that to you, that no, I don't want it. How do you typically respond to that?
I will sort of lean forward and try to make eye contact and very gently say something along the lines of, I worry about your child's safety without this vaccine. And I'm afraid maybe you've heard some things that aren't true. I would like us to talk about that so you could make the best decision for your family. You know, trying to be, I think any pushing is going to get a lot of pushback.
Right.
So just real gentle, trying to, you know, again, I tell them, you know, you can call me, we can ask questions. A lot of times it's like, my husband doesn't want it. And so I say, well, you know, he could call me. Here's my home phone number. He can call me anytime. I'm happy to talk to him. You know, he could come in with the kids. We can give this shot any day, anytime. You don't even need an appointment. You can just come in. So if you talk to him and change your mind, just come back tomorrow. I mean, we just try to make it so easy, you know, try to take every barrier away.
Yeah. Well,
but it's shocking to me that it's 60-70% of even the 5 to 11-year-olds that don't have it. I wonder what's going to happen with the younger ones.
thank you.
Yeah, they're saying, I mean, some of the stuff that's out there anyway is, you know, that it's an even lower percentage. It may be more like 20% of families are saying at this point that they would opt for a lot of other people saying they will wait. So I think we know that those predictions were pretty accurate last time around. So that's what they were saying was 30%. So I'm sorry, somebody unmuted. Carolyn.
No, I was gonna say, it's not gonna be helped by the fact that they're already saying it may not be efficacious in the 2 to 4-year-olds, and maybe they're supposed to be 3-dose, but they're going to approve the 2-dose. So we're going to be starting out the gate with, this is a new vaccine. It's your young kid. You want to wait to see what everybody else is doing, and it may not even work, because that's what the news reports have already put out there before its approval. So that won't help.
Yeah.
There are just two things that I try to remind the residents about. And one is, like, every patient that you interact with, just sort of take a deep breath, and it's a new conversation with every patient. Because I'm kind of surprised. Most people at this stage are refusing, but there are a few that you walk in and you say, oh, you're due for your flu and your COVID vaccine. And they say, okay. And I'm surprised when that happens because it's February, you know, you don't expect that. But you sort of have to just take a deep breath and be mindful, you know, that maybe there's something else that's been keeping people away. So I think of it as not over remembering all those negative conversations that you have, just so that maybe you'll have a positive experience. And then the other thing I try to think about, I just think, like, I end the conversation usually with patients saying, well, we're here whenever you change your mind. Anytime you want to make a nurse visit, you know, just give us a call. And I also tell them I'm going to bring it up again, you know, that's not the end of the conversation, without hammering them, because I do want to be gentle.
Such wise words. Sarah DeVicki just put in the chat. Oh, Sarah, do you want to speak to that? I don't know if you want to unmute and speak, but it's really, really a good point. People who are having serial quarantines all the time with their child and childcare. Oh my gosh. Yes, I do think that is a subset that will be very interested. Elizabeth just unmuted. Did you want to say something?
We've had 8 days of childcare since December 23rd for my 2 little ones. So I wonder if there's any partnership that could be done here. And LJ, this is something we could talk about offline with the daycares. If there's any guidance that we could be providing to them around vaccination, once it's ready, right? Vaccinations and isolation quarantines. I think they've been looking for that in general and have been kind of left out of a lot of the guidance. And it would be a big motivating factor. The text chain is going around every time the infant room closes. And so I know a lot of parents at our daycare, at least, are getting their kids vaccinated the moment they can.
We've
Totally
had
agree.
really good experience with our 5 to 11-year-olds. So I can get our numbers and our rates. I believe they're over 50%
That's great.
vaccination. So if anyone wants to hear how we approach it or what we're doing to contact families, we're using text messaging. So I'm happy to talk with anyone about the conversations that we're having or just the demographics that we have in our office. But our experience with at least that age group has been really good.
That's excellent. I'm sure people, I think at this point, the beauty of this is we learn together. And the more that people share their, either their obstacles and barriers or their successes, I think it really helps because you can't change everything that you're doing, but even just to take a little nugget, like that was just a really rich conversation. Mary Beth, I appreciate what you had to say. Cindy, those are just words of wisdom. And then I think if there's process and approaches that are working best, we should share those. That's how we got to this point. I think doing pretty well for this community on behalf of kids and families. So any other comments in this space?
I would make one more comment. The more that we can get out to the media and just the public that your pediatrician is the place to go. I keep hearing from people, oh, you have it here? Oh, you can do it here. A lot of times I'll say, okay, so today we're going to do your COVID vaccine. And they'll go, oh yeah, I have that appointment in 2 weeks, at the county. I'll be like, you don't have to have that. We can do it right here. And they're shocked. So that's a big message because I think that is a barrier when people have to make an appointment somewhere else and go, onto a website they don't know and see people they're not familiar with. If they know from the beginning, this has been approved, call your doctor, that information will help get rates higher.
We will continue to elevate that, Mary Beth. It's a really good point. I think with everything that we encourage that would go out in terms of PR around this, we would always say, and people who were speaking on this would say, you could reach to your pediatrician or your family physician. And there are other alternatives, but I think it's time to re-up that message again. You're right. We can encourage the teams at Adolescent Children's who are speaking to this. We can do some encouraging about that at the county level as well, so that messaging is clear. Joanne, you unmuted.
There's a commercial that plays or was playing for a long time about the mom that calls the pediatrician, and it drove my husband, who's not in medicine, crazy because he couldn't stand it. And he thought it was the just stupidest commercial. But I can't tell you how many people ask me, like, did you get your kids vaccinated? Like, they really do ask that question. So I said, the messaging really, it is true. They do ask us all the time. And I think, and some people have said, okay, well, that's enough. But so I think just being a little careful with how that messaging comes out is important too.
So, Joanne, you just made me think of something. I may have mentioned this on one of the Wednesday at noontime calls, but Adolescent Children's Pediatric Practice just did a mashup video. And I remember a lot of you participated in the old vaccine, my child is vaccinated, that one we did a few years ago. And a lot of you participated from your practices, but they did one just that featured some of their pediatricians and their front desk staff and some of their nurses and care coordinators. And it was just this beautiful, they put the messaging together and it just flows in such a nice way. And there's a whole section about, I love your questions, come and ask me your questions about the vaccine. So I'm gonna figure out how I can share that to all of you after this meeting, because honestly, with just a cell phone, right, with an iPhone, if people wanted to do something like that within their own practice, because that's what was meaningful about this video. It did not go out widely. It went only to the patients in the GCH pediatric practice. And I think maybe that's something that individual practices could do. It wasn't a fancy schmancy thing. So just somebody has a teenager could do the editing on it, and unless you're really savvy with it. But have heard that a lot of families really loved it. Cindy, I'm looking at you, you're smiling, but it was a really great job. And it's just been circulating out now, I think, in the last week or two. Am I right?
Yeah, and I think the diversity was really helpful. Just what you said, having people kind of from all parts of our practice was really, really helpful. And I think it's inspiring. But I actually haven't heard any patients comment on it yet, but that doesn't mean they haven't seen it.
That's great. All right, thank you. So I think we've exhausted the vaccine topic. If anyone, some people have shared some private comments in the chat that I did see. We really are going to be doing some targeted outreach to practices that have not been able to stand up vaccination. And this may be true for some practices that are involved in certain health systems or in situations where they may not have full control over whether to set this up or not. But regardless, we are going to be doing some outreach to help work with you. Jana has been doing a fabulous job pulling together like everything you could ever need now that we've all sort of figured this out together in order to do COVID vaccine in your office. So there's a nice toolkit, but we'll be reaching out for specific conversations. So for those who message me privately in the chat, I am aware and will follow up with you. So anything else COVID related that you want to talk about, or anything related that you want to talk about tonight?
I have a lot of Cepheid tests left because as soon as our shipment finally came in, we started testing at the school and we pulled it right out of the primary care office and nobody comes for testing anymore. And the federal government put test kits in every home. And I don't know what I'm going to do with all of these test kits, but
I don't have an answer for that one, Kareem. I don't know if anybody else has thoughts about that, because many of you ended up with the Cepheid machine. Some of you did other things, and
yeah,
it's been a frustration for this last 6 months. The only thing I would say, Corinne, is that now there's an offer in the chat to buy them. So I'm letting you all work on that. I'm not going to broker those deals, but definitely connect with Daryl's laughing. Definitely connect with each other around this because it is it's a tricky thing in that space. The other thing, what I was going to say is the school testing is not happening as much at this point now as it was before. It's the home antigen testing, obviously, a lot that is happening. But I think keep in mind, there's going to be, we don't know. Our chat already put out all the information about the fact, that the antigen testing is not so good against Omicron. Really, in fact, it's got terrible rates for detection. So PCR testing is still preferred, and I'd say hopefully those will still be utilized. The insurers are still paying for them, but privately, not so privately. Okay. Oh no, I'm now a test dealer. Oh man. Is this meeting being recorded?
Yes.
Of course it is.
Yes, it is.
All right, that's good. Okay.
Okay.
Yes, Liz.
Without bringing up the return to play thing,
go ahead.
In like 3 seconds, because
you can bring it up.
Yeah. I took the algorithm and your questionnaire, and I created basically a triage template for MedEnt that kind of goes through are you this year's old? And are you like, did you have these? So that if any other practice is interested in borrowing, taking that from me, I'm happy to have you do that. Just to make life a little bit easier. So it's there.
That is awesome. I'll add 3 minutes to your 3 minutes and just say, the other thing that we ended up developing this time around was this self-assessment, basically taking the questionnaires, the questions that you guys were asking in the office and trying to make sure this gets into the hands of families so that they can do the checklist. So that hopefully most of the moderate kids are going to still have been hospitalized, but not all of them. And so hopefully some will actually come to you who might not have made it otherwise, where they were diagnosed at home. And hopefully it will make that return for the 12-year-olds who have mild symptoms and they participate in sports. They can fill out that little self-attestation and get back in more quickly. The other thing we did, just as a resource to use if you want or not, everybody uses this information differently. But we took the self-assessment. So I'm seeing Sarah's comment. Sarah, we just designed a self-assessment that basically allows the families to walk through the questions that we had done for the provider assessment before. And then we've added to that a second page where you could, if it was easy in your practice, somebody's come in, you're like, oh, I want to do that self-assessment. You could hand them that. There's a page for you to say, check, reviewed self-assessment, and then physical exam, whether an EKG is indicated and whether the kid's back in or not. It has the whole thing. So we're finishing that up tonight and we'll be posting that on our website if it's useful to you. Liz, I know in the past you had loaded some things into MedEnt before. There's also a Buffalo pediatrician who's doing that with these things. So we'll share out MedEnt links. The goal right at this point with this whole thing, the AP revision was not as dramatic as all of us had hoped. It was really a very, very minor walk back a little bit in terms of the timing of things and in terms of the, when to assess and when a kid could go back and how they could go back. But our goal, quite honestly, was not to take a big step backwards either and create more work for you all or more work for the schools in this and just try to educate the community. We heard I don't remember who it was 12 Corners, Mary Beth. I don't know if it was you, but we heard the story at the noon meeting today about the child who was forced to do the PACER test the first day they returned after 5-day isolation with COVID. So I can't think of anything that I would rather not have a child do. It's almost worse than going back to their competitive sport. So I do hope we will get some more education in this space. Please do know that the hospitalist teams at both hospitals, at Gulf Center Children's, Rochester Regional, both EDs, the urgent care centers, all have been shared the parent infographic or the family infographic and that self-assessment form, encouraging them if they're caring for a patient with COVID or if they are testing someone, that they can offer those to the families so that they get that same education. So I think it's the best that we can do. And then I think we just have to try not to get mad at each other. Like try not to get frustrated with the back and forth. It's not easy. Carolyn, do you have other thoughts?
Sarah asked a question, but my understanding is most of these patients don't need appointments anymore. So to Sarah's question, they just do the self-assessment at home and then they probably don't need to come in, including the 12+ athletes.
The 12+ athletes who have mild symptoms, right? So which was the bulk of them. So this will diminish tremendously the number of kids who are needing to come in, but at the same time, hopefully elevate those who should be coming in, if they have been a little bit sicker with this, and hopefully just have people more aware. So if they see it, they're recognizing symptoms if they're happening. We just have not seen that many cases. That's the one thing I would say. However, we are seeing more MISC, and I said that on the call today, that we're seeing a spike of that right now. And the one little caveat I heard from one of our infectious disease specialists is they're seeing it before the 6-week mark. So if you're seeing a kid, 3 or 4 weeks out who looks like MISC, don't, pay attention, assess, call for help, and check that out. We're going to have infectious disease and actually Lauren Solon come to our next Wednesday noon meeting, and they're going to do a little brief panel Q&A about what they're seeing here locally and what it looks like in terms of national data around MISC. I'm sorry, we didn't hear about the rise in cases until just really just today, to be able to, we weren't able to bring them here to this meeting. All right. I'm going to look at the chat for a second. And while I do that, I'm giving Pat Brophy a moment to say a couple words if he would like to.
Sure. Thanks, LJ. So thanks everybody for letting me sit in. It's always good to hear what's happening and what the concerns are. Obviously, it's been a challenging couple of years. I think, hopefully, knock on wood, we're getting to at least the end of this wave and hopefully some kind of stability moving forward. Just wanted to let you all know that I've been asked to present the next vision for the Department of Peds and Adolescent Children's in May. And there's a few areas we're going to be working on, but I want to give a shout out to Dr. Hawania, who's been helping us try and figure out a better way to develop much easier and more direct access to the docs on call. And so we've actually been looking at a couple of different systems. And one of the things that has become very apparent is we're going to have oversight over that within the Children's Hospital as we move forward. And so that's going to be one of our main objectives for the next couple of years, to really build that in and hopefully support our community in a better way and more efficient way. The other thing that I just wanted to touch base on is we are going to start to look at developing some more specialized outpatient programs, working with Marge Arca, our surgeon in chief. We're actually going to develop a motility center, and it'll be I think one of two in New York, and it'll be the only one in upstate. And so we have a couple of terrific faculty members that will be joining us, and we'll start to move forward with some of these specialty programs. So just to give you an update, when we do our next State of the Department address, it'll probably be in September of next year. But in the meantime, once I get our vision set up, I'll try and make that available to Renee and LJ so that we could share it, or maybe we could even do it on a call like this. I will likely be reaching out periodically to get input from our community pediatricians, really focusing on how we can serve our kids in the best possible way. So the other thing I wanted to mention, and I have a dog in this fight since I'm the Pediatric Academic Society's program chair. I would encourage, if you can, to come and join us in Denver for this year's PAS meeting. We've actually expanded a lot of the components of it, really focused on the academia, and that includes a whole new behavioral health focus. So anyways, thanks so much. Thanks for letting me say a few words, and have a good night, everybody.
Thanks, Pat. All right, so if you can believe it, I'm going to be quiet for 15 seconds just to make sure no one has anything else they want to add. And we are going to end this meeting early. But I did just throw into the chat, like, if you are having trouble getting reimbursed for things that you're supposed to be reimbursed for, we have gone to bat a number of times with Excellus, with MVP, with New York State around this kind of stuff. So send us some examples, because now we've got like the right people to contact. So if you're having trouble, whether it's antigen testing or other stuff, please let us know. And we'll do our best to elevate that and see if we can get that resolved. Carol, Fidelis actually paid one. Oh my gosh. And that is like a New Year miracle. So no, I'm only joking. That's excellent, but not Blue Cross Blue Shield. Carol, you're killing me here. All right. We will continue to work on that space. I see no one unmuting. I see no one rushing to put on their camera. Thank you all for your time this evening. I hope you have a really nice evening, and we're going to do good work together this year. Take care. Bye-bye.
Good night.